I thought I'd start with an interesting story because, as was mentioned, I do have a background in Colorado. I was born in Fort Collins. I went to Lakewood High School. I spent 18 years in Boulder, and then I got dragged off to Washington, D.C., and my life was ruined. So it's a sad story from there. But I'm still a Westerner, and as you can tell by my attire, I was happy to shed my suit and tie and just come and be with you today, more as a Coloradan and somebody that really appreciates what you're doing and wanting to reinforce that. But also the work that I've done at the federal level and with Martha, it's really interesting. Our third was a gentleman named James Taves. He comes to the Administration for Community Living at HHS from Oregon State, and he was actually Martha's chair, I believe, at the time when they decided to change their name and be, broaden it to include the D in their name. And James then was coerced to come work for the federal government. He retired from his job out in Oregon and then went to work at HHS. And so he's still there today, and I guess he'll be back at his desk. It's too bad that he couldn't be here today because it really, I think, would show how well the collaboration can go between aging and disability organizations. And really, what I'm about to lay out for you is why I think it's critical right now. We have a really unique moment in history, and I'll start there. Really, with the passage of the Affordable Care Act, you have not just a coverage expansion, which is really how the law is billed primarily, but there's an awful lot of healthcare delivery systems reform elements that are built into the law. And I had the privilege of working on it on HHS, and it was really, it was just pretty expansive in terms of how it places incentives for both providers and states and the Medicare program to begin to think differently about how the public healthcare system is going to work in the future. And that part of the Affordable Care Act doesn't get an awful lot of attention. Another piece that doesn't is the Medicaid long-term services and support provisions that are in the law, which I know Colorado's looking at the community first choice option, and hopefully that's something that will go forward. We'll wait and see. That's good federal money there that will help the state. But back to the type of delivery systems reform that has been unleashed with the passage of the Affordable Care Act. It really focuses on hospital systems and doctors and helping them think about how they can perform better to achieve certain outcomes, patient-centered outcomes. So you're looking at real simple things in many cases like avoiding rehospitalization or hospital-acquired infections. But these are things that are quite obvious and perhaps should have been done a while ago, but now there's a real intense focus in our healthcare delivery system in making sure that medical errors and inappropriate types of treatment are rooted out of our system and basically gotten rid of. So the focus again is on this medical, clinical side of our delivery system. And the group that's gathered here today really is much more in touch with a community-based effort. And so I'm not forgetting that. I just want to bring it to that level because with the focus on reforms in our healthcare delivery system, it does reach all the way down to people that are living in their communities that rely on transportation, look for certain types of supports to go to work. And I think there's evidence that the medical system is wanting to learn from those of you that are really here to teach in many ways how best to support people in their homes and communities. And the evidence for that, some would say, well, what does that look like? And the fact that they've adopted this rhetoric of being patient-centered, they almost made it. There was a gentleman named Don Berwick. He's a real visionary. He was the CMS administrator, and we were privileged to have him for quite a while. And he brought this commitment to being patient-centered. But, I would always talk with Don about, could we expand that a little further to a person? And there, I think, some valid reasons why medical and clinical types really stay focused on patients. And that's because they have a robust evidence base that supports the types of medical interventions that they like to administer. But what I always like to point out is that they're really only looking at this individual at a point in time. It's just a snapshot of their life. When they spend 95 to 99% of their time outside of those clinical settings in an environment that the clinical and medical staff really struggle to comprehend. Think about all of the forces that are acting on someone when they're outside of a clinical setting, and yet they're being treated in these clinical settings as if none of those factors are going to act on them. But once they leave the doctor's office, as we know, they often complain about the difficulties they have in helping people comply with their treatments or stick to the plan of care that's been laid out for them. But that doesn't discount the fact that I think we really do see movement in our medical system towards being more person-centered, and the rhetoric of patient-centered approaches and the evidence base that they're pushing towards really starts to look now at how do people spend time outside of the clinical environment, and how can they incorporate that into not just the types of treatments that they administer, but how can they really better understand what the patient, what the individual, what the person does when they aren't in this very static status as a patient. So you all, I think, have quite a bit of perspective to bring to this. And if you're able to come together around just the diversity of aging and disability issues, I think you'll have an awful lot to share with the medical and clinical side of the house, which in the disability community there's a big concern about having these community-based services medicalized. I'm sure it's a concept that's not foreign to the aging community either. But there's power in engaging with the clinical and medical system. And I think it's because you are the groups that are most in touch with where people spend the majority of their time. And you can help the medical and clinical professionals better understand how they can design plans of care or a treatment protocol that will allow an individual to both adhere to it and to really benefit from it, because you'll have shared a perspective about what one's life is like in the community, and it will be incorporated into this clinical practice. It's going to take a while, but I think we're at the very beginning. So now to quickly get ready to set up Martha and to go on to this. Set up for a good thing. I mean, I think you really have a great opportunity with the groups that you have in the room to begin to focus on making additional investments. And I use home and community-based services in its broadest term. So it's not just applying to the waiver program. It's all of the home and community-based services that are available. I describe them as healthcare related. I don't talk about them as medical and social, because I think they're both essential to the healthcare outcomes that we'd like to see all people achieve. And I think by breaking them apart and talking about them as medical and social, it causes great dissonance in some people's minds, particularly payers, because they don't want to pay for things that aren't medical in nature. And the reality is that for people with significant disabilities or multiple chronic conditions, you're going to be paying for healthcare related services. And if somebody scratches beneath the surface and finds that they look like they might be a social support, so be it. But they are all healthcare related, and they're driving towards the type of health outcomes that we want to see. And why is that critical? Well, it's critical because people are making too many trips, inappropriately in many cases, to medical settings to have things treated that could have been treated better in a community-based setting had the appropriate interventions been in place. And that's just simply not happening in our delivery system today. You all have the keys to the future. The home and community-based infrastructure is not well developed. It's really, in many ways, in an infancy. And it really requires organizations to step up to a challenge. The organizations are undercapitalized in many ways. In our friends in the CCD community, really many of the folks aren't paid very much at it, or if at all in some cases. There are some paid staff in the advocacy world, but we don't really see organizations that are prepared to do the type of business that would allow them to interface with the clinical teams that are in desperate need of a counterpart in a community-based setting. And I did hear in the introductions that there are some organizations, particularly in the behavioral health arena, that I think are filling that space. But we don't really have it very much on the more traditional HCBS side in the elderly and disability arena. The exception, of course, is in the DD field, where I think we have a pretty robust system built. It's pretty stovepiped, as you all know. Hopefully by coming together and working together, you'll be able to share more generally about what works well for different populations and how you can grow capacity. And again, to reemphasize why it's so critical, if you don't build capacity in your organizations to both advocate for individual need and to provide service, you'll be at risk of having the medical and clinical types looking to invent the line of business themselves. That outcome is, I think, less desirable in that it runs the risk of being what one might call medicalized. And the best way to avoid that outcome is to have community-based organizations stepping up, starting to work more closely with the folks that are providing services in different organizations or even in medical settings, and finding new ways to build capacity so that you can make sure that the services that are being provided in community settings are informing what's happening in a medical setting. This is integrated care, care coordination. It has many different labels, but it really is at the center of the need for our healthcare delivery system to reform itself. Without having better integrated care, it will be hard for us to rein in the costs of our healthcare delivery. It's extraordinarily expensive right now, and I think people that are working in home and community-based services actually have a much more finely tuned sense of what cost effectiveness is than people in medical settings. And so you've had to operate on thin margins, and that's something that's not true in many cases in hospital settings. So thinking about how the providers can work more closely with the advocates so that you can have real groups of people that are working closely with the the rest of the healthcare delivery system is a central charge. I hope it hasn't just totally missed the mark, it's important and critical that the aging and all the disability groups come together and try to find the best way to work together. Today we have, we hope to have some exercises that will point new directions for you, but it really is time to roll up your sleeves and reach these outcomes. They're not just important to the governor, they're important to the rest of the country. We spend, 2 to 3% more of our gross domestic product on healthcare than any other country in the world, and it's because we're really inefficient. And we can change that, and it can change by starting at the community-based level and finding new ways for you to forge relationships with the other people that are involved in delivering healthcare and holding them to account for the real interests of the populations that you either represent in your advocacy efforts or actually serve as a service provider. So with that, I'll hand it off to Martha.